Talks on the End of Life, a series of public forums on how to handle the challenges of aging and the final days. Number 3 in a series, Hospice 101, sponsored by St. Barnabas Episcopal Church with Hospice of Cincinnati.
So thank you so much for being here. How many of you have been to the other talks? You know, so many of you. Today we're going to talk about hospice and what it is and what it isn't. And I think that there's a lot of myths about hospice, and we'll touch on those. I think hospice is likely one of the best gifts that we have in terms of medical care. From a Medicare, Medicaid, and private insurance standpoint. I really do believe that if it was in the Healthcare Act today, a lot of people would say that that's too much care, that it's too generous, because it is indeed a generous benefit that literally doesn't cost the family or the patient anything. It really is a free benefit. So we'll get into that a little bit. Stop me if you have any questions. Because we're on tape, I think I'll repeat the question just so that we can get that heard. But if you have any pending questions, please, let me know right away because I may answer them and I may not answer them. And if you have the question, somebody else does as well. So just a little bit of industry. 2.4 million people die each year, but only little over 1 million are in hospice care, which is just 44% of patients who die each year are in hospice care. Yet, 70% of patients under Medicare who die each year have chronic illness. So when you have a chronicity of illness that you could expect to be terminal, yet no one talks about the end of life, and there's no planning on what should we do in case this disease turns terminal, that's where the gap is, and that's what we're working on as a community and also as a hospice provider. Many of you know we just got a $2.5 million grant from Bethesda Incorporated to teach physicians and advanced care plan practitioners in their offices how to have end-of-life discussions with patients and families. It is vitally important that we get comfortable with this topic because we're all going to die. I have a sticker on in my office that a dear friend gave me that says, "Spoiler alert, everybody dies." But we sure don't act like it. It's really very funny, and it's a hard topic. This is tough stuff. And 4 years ago, my dad died, and I was very, very, very close to my dad. And for those men, there's nothing like being a daddy's girl. It's the best thing on the planet, right? It is just phenomenal. I didn't want my dad to linger in the illnesses that he had. I can tell you, I saw him in Texas in March, and he died in June, and I didn't see him in between. I was in China when he died, and it was the longest plane trip on the way home. It was just excruciating. But what was more excruciating was when I said goodbye to him in that last evening that I was in Texas in March, knowing that I wasn't going to see him again. It was excruciating. But then when he died, it was okay because I didn't want him to linger the way he was. So my dad was very pragmatic, and it was really okay. And so I think that there's sometimes opportunities for people to grieve before the death. That happens a lot in Alzheimer's, right? And so I was really okay with my dad because I think I felt like I lost him before he died because he had a neurological disorder that really didn't keep him with me. He would go off, and he had moments of clarity, but those were fleeting. So when he died, it was really okay. But I had the opportunity recently to be with a dear friend of mine while her mom was going through end of life, and she lived in Blue Ash, and I work in Blue Ash, and so I just would run over to her house during the day. And for the first time in my life, I know what it feels like to lose somebody so dear that you can't imagine them not being around. I didn't get that. I didn't get it with my dad because I was okay with that. But this dear woman who was 82 and so funny and so present and just so full of life, I can imagine what it's like to not want her to go away. Even though she was in hospice care, she was okay dying. Her girls were not okay with letting her go. And I get that now. And I'm 53 years old and I've been a nurse for a long time. I didn't get it before, but I get it now. And I know that that's where families are when we get them. We have to meet families where they are because they may not be ready. The patient might be ready, but the family might not be ready. And so we have to figure all of that out. So we know that this is really tough stuff, which is we have a reflexive response to just turning away from that information. And that's why we have a gap of between the chronic patient who we know is going to die and them admitting that and saying, let me have hospice care because I want to make sure I have a good death. 7,000, it's actually probably closer to 10,000 baby boomers turn 65 every day for the next 17 years. We have to do something about healthcare costs and all of this futile care that we do at the end of life because we can, because death has become so medicalized. When a family gets, when a patient gets a diagnosis, the family gets an illness, right? And the whole family suffers. It's not just that patient, it's the whole family. And so what hospice does is take care of that whole family. So in the last 6 months of life, 42% of us are gonna have 10 or more physicians. Who coordinates all of that care? So who's going to tell you you're terminal? Is it your cardiologist or is it your primary care physician? Is it your endocrinologist who's taking care of your diabetes and your gout? Or is it your GI doctor because you've got this something going on with your stomach chronically? Who does that? Is it your oncologist? Most of the time, the specialists will say, it's not me, I'm not the primary care physician, it's the primary care physician. But the primary care physician says, I haven't seen you in years. You've been going to all these specialists. I don't know what's going on with you because doctors don't talk, because their computer systems are different. That's changing and that's getting a lot better. But this is a real problem. And so we have to decide who's the attending physician, and then we'll keep in touch with those specialists who still want to know about you, but they're not going to direct your end-of-life care. It's going to be your primary care physician.
Yeah, and that's a hospitalist who's never met you before you got into the hospital.
The hospitalist is the person who probably writes the order when you're in the hospital for hospice, and they won't be your attending physician because they don't follow patients outside the hospital.
Right.
So they have no idea who you are.
I think if you didn't know you're going to die, or maybe, and you came into the hospital and the hospitalist was your doctor,
Yep.
It's striking because the primary care docs maybe don't have privileges there.
Exactly.
So it makes things worse rather than, I think, better.
That whole communication component, Peter, makes everything complex.
Why don't you repeat the question, Dick, when you're...
He was saying the hospitalist is not going to be the person directing your care, and they also don't know you. And so you could kind of say they don't really have any skin in the game. They don't know you. They don't know what your beliefs and values are. They don't know your family's coping mechanisms. They just look at the diagnoses and the numbers and the lab reports and path reports. And so there's a real disconnect. And that's why it's really important to make sure that that hospitalist communicates with your primary care physician. And so your primary care physician, who knows you best, understands what's going on.
Can you define a hospitalist?
Okay, so the hospitalist is a new, yeah, that's okay. The hospitalist is a new group of physicians. It's been in place for a number of years now, but it's fairly unfamiliar to those of us who don't spend a lot of time in the hospital. The hospitalist practices in the hospital, is employed by the hospital, and only sees people in the hospital. So your primary care physician, say you have an internist and he's your doctor, when you go into the hospital, very likely that doctor isn't going to see you. It's going to be a hospitalist. And the hospitalist will direct your care and manage everything about your care while you're in the hospital. they'll consult with an oncologist, a pulmonologist, a cardiologist, whomever, while you're in the hospital. And they'll discharge you to your primary care physician when you leave the hospital. So they don't see people in the community, and they have no offices. They make rounds every day in the hospital. Did you have a comment?
Yeah, if it's the same thing as if you're in a nursing home also.
Right, so in a nursing home, the same thing occurs. So that means that your doctor, if your doctor visits nursing homes, which some of them do, and that's great, but some of them don't, and so then you will be under the direction of the medical director for the nursing home. Yep, that's exactly right.
As a matter of protocol, if the hospitalist discharges the patient to the primary care doc, can the patient's family assume that the primary care doc is going to get all the records from the hospital?
That's a good question. So if the hospitalist discharges you from the hospital, how does the primary care physician know what just happened to you, or that you were even in the hospital? The beauty is through the EPIC system, which is the electronic medical record, and also we are a Beacon grant community, meaning that we've gotten federal government dollars to integrate the systems, the computer systems in our community. So all the hospitals are on the same system. So it doesn't matter if you're at Christ and your doctor's in Westchester, the Christ physician or the Christ hospital will send their your medical records to your doctor in Westchester. So they all talk to each other. And so physician practices are getting on the same system the hospital's on, and the Beacon grant is a bridge that allows all the systems to talk to each other even though they're in different settings, and they belong to different healthcare systems, because TriHealth is different than Mercy, this is different than Christ. Good questions. So what happens when you have a late referral to hospice care? So some of you have seen this slide already. What happens is if you're given 6 months to live, but your doctor says, well, we could still do some things, and he doesn't say that you have 6 months to live because we're still trying this treatment, and then 3 months into that 6 months, things aren't going so well, and so now, we're going to start talking about hospice, but because this is so new to you, you put that off for a month or two, and all of a sudden you're referred to us in the last month or week or 2 weeks of life. In that transfer at that time, you're in crisis. You are absolutely dumbfounded that we've been doing this treatment all this time, and now all of a sudden we're talking about end of life. It's stunning. You're asked to change the care team that you've been dealing with. So you've been dealing with the physician's office, maybe the nurse practitioner, maybe the PA that works for the physician's office in a whole physician's practice. So while you're there and you're taking your loved one there, they're checking on you to say, how are you all doing? Is the family doing okay? Are you doing all right? And are you eating? And we've noticed you lost weight, because they know you and you're part of the team. Now all of a sudden you have to change because that doctor's not going to direct your care anymore. They're going to send you to hospice. And that's very difficult. So the patient and the family often feel abandoned by the physician. And they feel like it's giving up and letting go, rather than easing into a diagnosis and easing into that last 6 months of life. When you switch when you're referred to a hospice in the earlier trajectory of a 6-month lifespan, then you get to gradually introduce those services that you need. We don't deliver a hospital bed right away. We'll deliver a hospital bed when you need it, and that may not be for a number of months. We won't deliver all this equipment. You get to know your nurse, you get to know the aide, and in the beginning you might not need an aide. As you get closer to the end of life and your spouse and your family's really burdened by the amount of care that you need, and guess what? They're not nurses. I am, but they're not. And you don't know how to take care of somebody. You have to learn that over time. Then you get an aide when you need it. And so in the beginning you might not need an aide, and then all of a sudden it's harder to take a shower, you get weaker, and so now the aide comes every other day or every day if you need it. Then the chaplain comes and hooks up to your pastor and invites them to come. And then the counselor comes and they watch over your family. And the volunteer comes so that the spouse can get a break and go get their hair done or their hair cut or go see their buddies at the coffee shop. So you have all of these resources that come to you gently and gradually versus, holy smokes, we've got an open revolving door in our house and this is overwhelming. Do you have a question?
You're talking in a mode that I think you're saying that you're talking about the person still living in their home.
Absolutely.
As opposed to your facility.
That's right. 90% of the care we provide is in the home. And they live and they die in their home. Or the place they call home. So that could also be a nursing home, an assisted living, independent living. It could be your daughter's home. It doesn't necessarily have to be your home. We have taken care of homeless people under a bridge. That's their home and they don't have a home. And that's their choice and they don't want to move into our inpatient unit. And I'll talk about the different levels of care and when do you go into an inpatient unit versus being at home. I think it's one of the big surprises is that people don't realize hospice care keeps you at home. It allows you to be in the place that you desire most, that you are around the things and the people that you love. That's one of the huge benefits of hospice.
I'm confused about whether hospice care precludes, when you said you get new care, you get different staff.
Mm-hmm.
Does your primary care physician then hand off care to hospice and is no longer involved?
No, in fact, we really want, if the physician's comfortable with it, we really want the physician to stay involved with that patient's care if they want to continue directing the care. Oftentimes the physicians aren't comfortable with our level of medications. It's unfamiliar with them, the dosing that we use sometimes, pain medications especially, and sometimes some medications such as Ritalin. We use Ritalin for an energy booster for the patients that are really tired from chemo. We give them Ritalin and it boosts them up and it gives them energy. Many physicians aren't aware of that that's how it works for adults and end-stage life adults. But the family physician can stay in contact. The patient can also go to the doctor's office and see the doctor if they need to make an appointment and go see the doctor. They can do that as well. Most of the time, they don't go back into the hospital because they've chosen no more aggressive treatment. And so our objective is to keep them home and comfortable. But we really want the family physician and the primary care provider to stay in contact. They may not, and then our medical director takes over and directs the care. But oftentimes we make contact with that provider, so we'll give a little nudge to the primary care physician and say, Mrs. Jones is doing really well. She'd really appreciate hearing from you because you've been her doctor for 20 years. And the doctor's more than happy to call up and say, hey, I know you're getting good care. Hospice is keeping me informed. And that's a huge benefit for the physician. It's a really big benefit for the family. Yeah. So the important needs going unmet. If we die in the hospital, 90% of Americans want to die at home, yet only 25% do. Most of us die in the hospital. And I would wager a bet to say very few of us want to die in the hospital. When you do die in the hospital, oftentimes you don't have enough contact with physicians. You're not given the emotional support that you need because they're really focused on the patient and they're trying to save lives in the hospital. There's not enough information about what to expect in a dying process because they're not as familiar. Their deaths are quite sudden oftentimes. There's not enough emotional support for the family. And oftentimes they're not great at giving medications that reduce shortness of breath, pain, and anxiety. And so we are specialists in pain and symptom management at the end of life. And not to say they do a poor job, they do the best job they can. Their focus is different, very, very different than ours. So what do we want at the end of our lives? This is a poll that was done in, I think, 2006 in a peer-reviewed journal. And most of the time, patients want pain and symptom control. They want to avoid that prolonged dying process. Sometimes, you know, you've heard Woody Allen say, I'm not afraid to die, I just don't want to be there when it happens. It's sort of along that line. They want a sense of control, and hospice gives you that because you get to direct what this is going to look like. How tolerant are you to pain? If I give you all the pain medication you might need, you might not be as alert as you want to be. So tell me, where do you want to be? Do you want a little bit of pain and be alert? How much do you want us to control these symptoms? Sometimes it's literally get rid of my hiccups and I'll be just fine. But sometimes hiccups are, there was a gentleman I heard a story about, not in our program, but this wife told me that he had hiccups for 2 weeks and nobody could get rid of them until he went to hospice care, and the nurses said, know exactly what to use. And they got rid of his hiccups so he could eat, he could talk, he could sleep. Prior to that, he couldn't do any of it. When we're at the end of our lives, we want to reduce the burden on the family. One of the biggest issues hospice patients will say is, I don't want to be a burden on my family. And that's where hospice comes in, and we help the family care for you. They want to strengthen the relationship with the family, and most of us want to die at home. Some of us don't. There are some people who say, I don't want to die at home because I don't want my kids to walk into this living room and think that's where mom's bed was. And so we can figure that out. We can make those arrangements. What caregivers want is they want their loved ones' wishes honored. They want to be heard. They want to be a part of the conversation. They want support at home. They want to know that there's somebody there that if they have a crisis, mom can't breathe, I don't know what to do. In the past, just call 911. Okay, now it's different. You're in hospice care. You pick up the phone and you call us. We are the 911 for hospice patients. So that care and support in a crisis is available through our call center and the support team that will come out to the home. They want honest information. Most of us can handle the truth as long as you deliver it in a compassionate and an empathetic way, and it's supportive. So they don't want to be abandoned by the healthcare team. They can handle it as long as they know that there are people there to support them and that they're not alone. I think most of the time, families will say, I felt so alone. I didn't know what to do. I had to make all these decisions, and I didn't know. I'm not a medical person. I don't know what to do. They need transportation. They need medication. They need medical equipment. And they need to be remembered and followed after their loved one's death, which was a federal mandate that hospices across the country will follow that patient for 13 months after, follow the family for 13 months after the patient's death. It's the law. We can offer you that counseling. You don't have to take it, but we have to offer it. And Hospice of Cincinnati is so dedicated to this. In 2011, we opened up the Goldstein Family Grief Center that offers free grief counseling to anybody in our community who has lost a loved one. Doesn't have to be through our hospice or any hospice. And then also we own Fernside, which is a center for grieving children. And we promote that artistic expression of loss in kids. I think it's 3 years old to 18 years old. And so we support them out of our profits.
When do you admit patients to the inpatient hospice unit? That's next.
Yep, it's coming up, Peter. I will tell you what the levels of care are. So that question is, when do you admit patients into the inpatient care unit? Or better said, through the voice of the customer, when can I go into your unit to die versus dying at home? What makes me eligible? And I'll get to that.
How do you know about this part of it? I mean, at what point and who lets you know?
About the grief services and all of that?
Or when a person is
Ready?
or
So when do you know when do you know how to ask? Are we at that end stage or
terminal and they're still doing everything?
futzing around with different treatments and all of that?
Yeah.
So there's a couple things that you can do to set a level playing field with your physician, and you one of the resources that you have is one of our previous talks was Dr. Beckhold, who told us how to talk to our doctor. One of the things that you can do when you know an illness is serious is say to your physician, how comfortable are you telling me when things don't look good and when things look terminal? Are you comfortable, and will you share that with me? And if they say, well, I don't really like to say, I prefer to know that information, if indeed you do, then you just say, I prefer to know the information. That's how I am, I want to know. And so you let them know if there's a serious illness that is turning into a terminal illness, I need to know that. Yeah. So, but there's some other questions we can ask. So what's the difference between palliative care and hospice care? So palliative care is kind of a newer term, and palliation means to make better, to free the patient of symptoms. Palliate or palliative radiation is radiation that isn't going to cure, but it's going to reduce the tumor size so the patient feels better. Palliative medicine is the treatment for symptom management. So let's say you've got chronic back pain. It's not terminal, but you need pain control. You'll go to a palliative medicine doc and that are specialists in pain management, and you'll get your pain taken care of. That's what palliative medicine is. And it can happen anywhere in the spectrum of illness. You're not terminal, you don't have to be terminal. They can also do end-of-life discussions as well as advanced directives. So they're skilled in having those conversations. Hospice is a form of palliative medicine in that all we do is pain and symptom management, but you have to be terminal to be in a hospice program, meaning that you have 6 months to live or less if your doctor is good at predicting. And should your course, which is probably not usually the case, but and should you have 6 months or less, should your course follow its natural, or should your illness follow its natural course? So hospice actually extends life, and why would that be? So imagine the cardiac patient who builds up fluid because your cardiac muscle is a pump, and the pump's not working so great, and so you build up fluid in your lungs and in your legs and your hands and your arms. So our nurse goes out to see that patient every week, and rather than having the patient go into a crisis because now they built up all this fluid, our nurse sees that, calls the doctor, gets Lasix. We give Lasix, the patient settles down, starts peeing out all that fluid, and now the patient's averted an ER stay, visit, crisis. So that's one example of why cardiac patients do so well, because we monitor them so closely. So when you're in the home, our nurse comes every week, more often if needed. We've had patients where the nurse goes to see them every day. And so we monitor patients a lot more closely. And we do that same thing if the patient resides in a long-term care facility. So we see them more often. The other thing of why patients live longer is because they've stopped all of that medication that makes them sick. And they just feel better. They start eating again, they start having more energy. It's a pretty good deal. They just have, they don't take the horse pills like the vitamins. I mean, if you're dying really, why do you need a vitamin? Why do you need all those where's those, we take you off everything that is non-beneficial. If it's beneficial, it's going to keep you alive, it really is going to make a difference, absolutely, keep on it. But if it's not, and it's just more medication, and in fact, all those medications have interactions, we try and get you off anything that's not necessary. John?
This is from a non-medical person, and it's more of a hospital question than a hospice question, but going back to your last slide, where you talked about palliative care, they tended to make the patient feel better, and it being given at the same time as life-prolonging treatment. is that to suggest that in the old days, hospitals just tried to prolong your life and didn't particularly care if you felt good or not?
Well, I think, you know what, so that's so interesting. So I started out in '85 as an oncology med-surg nurse. And I know, based on the medicine we deliver today, we were not as into pain control and comfort measures as we were then. I mean, as we are today, we were not that well informed then. So I think we were more afraid of medications and narcotics. I don't think that we understood how activity and getting back into, I mean, if you had surgery, you laid in bed. Today, when you have surgery, you get up that night, if not, you know, sooner. I mean, you're up and moving around, and so you don't have the complications of immobility. Everything has changed so much that we're more well informed, but along with that comes medicalization of end of life. So we've done so much to medicalize. And Dr. Byock, who's a well-written physician, says death isn't a medical issue. It is a developmental stage that has tremendous medical needs. We're all going to die, and we all have to go through that developmental stage, just like you did when you were in preschool and you went to school and then you went to college and you got married and you had children, you sent your children off and you got health care insurance and you planned for retirement. End of life is a developmental stage, and we kind of act like we don't need to go through it, we don't need to deal with that. It is a developmental stage with a lot of medical needs, but it is not a medical issue, it's not a medical disease. It's developmental, and we need to treat it that way. And be more comfortable with it. And we're just not. I mean, this is huge that St. Barnabas has taken on this series, because it's I think, a reflection that we are trying to become a conversation-ready community. And that's really phenomenal from our perspective. So who's appropriate for hospice? This is to your question of when do you know? You ask the question, would I be surprised if this patient died in the next 6 months? If the answer is no, I wouldn't be surprised at all. Then let's start talking about end of life. What do I want for the end of my life? If the answer is yes, I would be really surprised. Make sure we have advanced directives in place. In one of our previous talks, a gentleman, one of the parishioners, said that his brother, who was in his late 50s, died suddenly last year and was astonished that all of his medical paperwork was already done. He had advanced directives, he had a living will, he had his whole estate in line, and he literally had to do nothing. He said, we had no idea. Here's a single man in his 50s, dies suddenly, and what a gift, because we didn't have to deal with any of that. He did that for us. So if I wouldn't be surprised, now the reason why we say in the next year is because physicians are very bad at prognosticating end of life. They over-prognosticate by a factor of 5.3. So if anybody's statistician in the room, that's 530%. Why? Because they love their patients. They went into practice to save lives. They were never taught how to talk about end of life. They strive to keep people alive. But they forget that as a physician, and Peter can talk to this, it is one of the most rewarding things that a physician does is to shepherd their patients and families through the end of life. Physicians who are really good at it find it very rewarding, but it's scary and it's hard. So what is hospice? So this is a federal benefit. I'm telling you about Hospice of Cincinnati, but this is a federal benefit through Medicare and a state benefit through Medicaid that follows Medicare guidelines, and so the benefit's the same. And many private insurances will follow the same guidelines with Medicare, but it's a benefit that is, for Medicare, the same throughout the country. So if you have a loved one who lives in another state, this is the same benefit. So nothing's changed except what a particular hospice offers. So who qualifies? It's a terminal diagnosis with a life expectancy of 6 months should the disease follow its normal course. It's multiple diagnoses. So Cancer, 61% of our patients don't have cancer. Only 35% of our patients have cancer. So there's a large group of people that just think hospice is for cancer patients. So it's for pulmonary patients, sepsis, heart disease, stroke. And failure to thrive is a new diagnosis that CMS has decided they're not going to pay for, and so we need to find another diagnosis, which is sometimes hard because patients, we have had a 105-year-old patient who didn't qualify for hospice because there was really nothing wrong with them. And the lady was just old and frail, but she was eating okay, but she really didn't want to live anymore. But we couldn't do anything about that. So there are some times where people kind of get what we can call the dwindles. They just kind of start pooping out on you and you don't really know why. And if we can get them into hospice care, great. But if we can't find a diagnosis, do we really want to admit them into the hospital, find a diagnosis, only to put them in hospice care? Many of our patients don't want to go through that. And so they're not willing to go into the hospital just to get a diagnosis. Because why? I'm at this stage in my life, I'm not going to treat it anyway, so why would I do that? So sometimes it's hard to find a diagnosis. Dementia, I'll show you what that looks like on a graph, but that's a hard one. So Medicare, Medicaid, private insurances pay for this care, and it provides 6 months of end-of-life care. So literally there's no out-of-pocket costs. Hospice nurses, physicians, the whole care team are specialists in pain and symptom management, and we have designed specific pathways of a patient has cardiac disease or they're a pulmonary patient, and we do certain things at certain times and watch their progress. All medication related to the diagnosis, so that means any medication that the patient's on for life-sustaining, any treatment that the patient gets is delivered to the home through FedEx. There's no more going back and forth to Walgreens and CVS and Kroger Pharmacy. Everything's delivered to the home, as well as all the medical equipment. So when you need a hospital bed, we'll deliver that. When you need a commode, if you need a wheelchair, if you need a walker, if you need a bedside cabinet, if you need an overbed table, all the medical equipment, the oxygen, all of that is delivered to the house, delivered to the patient's care site. And then if you're in a crisis, so in the middle of the night, always happens in the middle of the night, mom can't breathe, she's in a pain crisis, I don't know what to do. The family can call us. We have 24/7 phone availability of a nurse to call on the phone. They may direct you and kind of triage your need over the phone, or they'll get in their car and come out to see you, no matter where you are. So we've got 10 or so nurses who work all night long just waiting for a phone call from a distressed family. So that is the care that's the 24/7 care that we provide to families. Why we're different is that we have 4 inpatient care centers, so you're all familiar with the one in Blue Ash. We have one in Anderson. We have one in Westchester, which is the 5th floor of the old Mercy Western Hills Hospital. The hospital moved out, but we're still there. And then we have one in Hamilton. It used to be in a bread factory, I think, up on Hamilton Road, or on Eaton Avenue. And we provide holistic cares such as pet, music, art therapy. So we have a pet peace of mind program where we'll care for the patient's pet in the home because they can't empty litter box and it's downstairs in the basement and she can't get to the basement anymore. And so our volunteers go out and empty those litter boxes, pick up the remnants in the yard, take the dog for a walk, take the dog to get clipped, take the cat to the vet, etc. The Goldstein Family Grief Center, I talked about that before, grief services for everyone in our community, and Fernside as well. And the important thing is that we are the only nonprofit hospice in this city. And so studies show that nonprofits have 14% more RN visits, registered nurse visits, than for-profits. Their business model's a little different. What I will say is are the nurses any different? I think if you're a hospice nurse, you're a hospice nurse because this is a calling and you will deliver the very best care at the patient's bedside. So I don't know if the nurses are any different in a for-profit or not-for-profit. It's just the It's the pressure you get from the corporate office and what the goals are and how often you can make visits and how quickly those visits have to happen and that kind of thing. But the nurses have patients at the center of their heart. So the model of care, again, should be the same everywhere. This is a federal benefit. So the patient and family are in the center. The physician looks at that patient's chart, talks about this patient every 2 weeks in a group setting with the care team. The spiritual care is through our chaplains, social workers, grief counselors for the family left behind for the next 13 months. Home health aides, the pharmacist is on the case always, the RNs, and also the nurse practitioner will come out and see the patient face-to-face every 3 months. And then our volunteers. We have 500 volunteers who give us 40,000 patient hours a year. Yeah. By law, you have to have 5% of the care delivered by volunteers. We provide 8% through volunteers. So the levels of care. So this is going to answer the question of when do you get to go into an inpatient care unit. And if you look over here, my clicker's now. If you look over to the very right, that's general inpatient, would be in one of our 4 inpatient care units. And that's for, picture this, so you're in the hospital and you get enrolled in hospice and you go home and you're doing pretty good. You're under what we call routine home care, which is our nurse comes out once a week, our aide comes out as needed, every other day, every day, whatever you need. Our chaplain, social worker, everybody comes out, we deliver the medication and all the equipment for you. That's routine home care. But then you get into a crisis and the medications don't seem to be working, or you can't stop throwing up, or something's changed and we need to get you balanced. We'll send you into our inpatient care unit, and one of the 4 will transport you by ambulance, manage your symptoms, control your symptoms until they're kind of even keel again, and then send you back home where you want to be. That's what the inpatient care unit is. Oftentimes, we will send a patient to the inpatient care unit directly from the hospital because you've been getting all this aggressive treatment. We've decided that this is kind of what we're doing now. We're going into a hospice care, but we don't have your pain managed yet. You'll kind of make a pit stop to our inpatient care unit, get you settled and stabilized, and then you can go home. Oftentimes, it's very sad, but oftentimes the patients come to our inpatient care unit and they never go home because they're so sick and they're so close to the end of life. Sometimes the patient will get a hospice referral and will get to the hospital when they're actively dying, and we will care for them in place with our team. Will come in and help manage the care right there in place. 25% of our patients die before we can get there. That's how late they're referred to us. Continuous care is the same type of kind of that intense care, but you're in the home, so same thing, you're in the home, you've got a crisis. We may say, we're gonna send you into the inpatient care unit because that's what the family is really comfortable with. Or let's say mom absolutely doesn't wanna go anywhere. We will send a nurse out to the home and provide one-on-one care until that patient's stabilized. So the nurse stays with that patient and they rotate shifts until that patient gets stabilized, and that's 24/7 one-on-one care. So that's the same level of care as general inpatient. We just didn't change the site of location of care. And then respite care is really a phenomenal care level where, let's say you're in routine home care and you've been in that home care situation for a couple months, you're doing okay, but the family has a wedding in Kentucky and everybody really wants to go to Uncle Joe's wedding. And so Dad goes into the inpatient care unit and stays for 5 days while the family goes to Kentucky and goes to the wedding. and they come back and they get settled and they go pick up dad and bring him home again. That's respite care. You can do it for up to 5 days at a time. There's no limit to the number of episodes you can have. But we've not really had anybody abuse that. So the hospice triggers, this is the trajectory of what it looks like at the end of life when the patient has cancer. You're kind of plugging along and doing pretty okay until the bottom kind of falls out. And the end of life for cancer is kind of quick. The families will say, wow, this happened really fast. And it didn't really happen that fast. It just wasn't talked about and people just didn't notice.
Okay.
And then in terms of end-stage heart disease, you'll see that people will kind of go on a little bit of a roller coaster, and every time they hit bottom, they've gone into the hospital, and every time they come out, their new level is just a little bit lower than it was before. And that sometimes isn't real noticeable, but it's surprising because they've always come out of the hospital, they've always rallied, and then all of a sudden they don't. That's the really tough part. The pulmonary disease is sort of, Dr. Eisentraut, who's over here in Montgomery, describes it like a skipping stone. So you skip a stone across the water, and there's big skips, and as it skips along, it's lower and lower and lower to the water. And at the very end, the skips get really close together. If each one of those is a hospitalization, at the very end, you can't get over your illness in one hospitalization before you get sick again, and you just keep, excuse me, sorry, Chris. You just keep, it's very difficult to manage that. So you'll see the patient who normally had been really well controlled, short of breath, at rest, unable to walk very far without oxygen, holding on to equipment, in the hospital repeatedly, more and more infections. And then dementia is really tough. So oftentimes there'll be anywhere from a 6 to 8 year span of the time it takes from diagnosis to the end of life. And one thing to note too in that is the family often grieves much sooner than end of life. The saddest part isn't the death. The saddest part was losing that patient earlier in their disease state and how difficult that is for families. But they can't mobilize themselves. They often can't hold their head up. They don't eat. They have trouble swallowing. And they're incontinent oftentimes, but they lose their ability to smile. And that's often kind of a trigger. People who are around these folks generally say, boy, things are really going downhill, and I don't know what's wrong, but something's different. So hospice care is really how you live. It's how you love, how you want to spend your end of life with your loved ones. How comfortable do you want to be? That we can still create moments of peace and joy. We can still create closeness in families and really be at peace. It doesn't have to be so crisis-ridden. It's sad, but you don't have to be in despair. And I think that that's really important. So one quote that I really like, Dr. Collins was the medical director over here at Bethesda North, and he said there's a fine line between acts of prolonging life and prolonging the act of dying. And you know, 100 years ago, we didn't interfere with that. Today, we interfere with it much more than probably we should, because we are so death-denying. And the middle article is from the New York Times. There's a great blog called the New Old Age blog, and it's a New York Times blog. And this gentleman said, you know, I'm not really alive, I'm just not dead yet. He had prostate cancer and he had been getting treatment for 12 years, and he just said, this isn't living. And that's kind of how I felt about my dad, because that's what he said, this isn't living, Janet, I don't like this. So I think I talked about that one. So these are all resources. Is hospice care the right choice for my family is on the back table. They're all available at hospiceofcincinnati.org. So you can get any of these resources offline. But hospice care, is it right for my family, will give you sort of the main points of what the myths of hospice are and the right answer to the questions. And then 4 things that matter most. Sometimes when we are struggling with having an end-of-life conversation with our friends and our family and our doctors and our kids and our parents, it's because there's some barrier that's holding us back from having these meaningful conversations. Estrangement, lots of terrible things happen when people die. So these are 4 things that you can say to open up that conversation and take the opportunity when something arises. The death of a spouse, deterioration of a loved one, a diagnosis. A decade has passed since you spoke about this last. And there's one more, and I don't know what it is, but it's in the brochure. I'm blanking right now. There's 5 Ds. So that's it. Thank you so much.